Thank you for joining the Society of Thoracic Surgeons Advocacy Training webinar. This briefing will provide background information to prepare you to engage members of Congress and their staff members during the upcoming legislative fly-in. My name is Courtney Yo. I'm the Director of Government Relations for STS. I'd like to introduce my colleagues Josh Krantz, our Political Affairs and Advocacy Manager, and Madeline Sterling, our Government Relations Assistant. Together we will walk you through the following topics: the current climate on Capitol Hill, a policy primer and overview of STS actions regarding the Medicare Access and Chip Reauthorization Act, or MACRA, and congenital heart disease research funding. Finally, we'll discuss the STS Political Action Committee and STS advocacy resources and how they impact policymaking on the federal level. Typically, Congress does not pass important legislation during an election year. Party leaders intentionally reduce the legislative work schedule to allow members ample time to campaign for re-election at home. The lame duck session, which is the roughly 2 months bookended by the November election and the start of the new Congress in early January, is often accompanied by a surge of activity from lawmakers who are freed from the specter of an upcoming election. However, sometimes activity in the lame duck session stagnates as policymakers set their sights on leveraging the new political dynamics of the new session. That said, the work we do in the present can often bear fruit in the future. It is important to recognize that our advocacy efforts do not have to ebb and flow along with the pace of Congress. The most important acronym in healthcare policy this year, and likely for many years to come, is MACRA, the Medicare Access and Chip Reauthorization Act, signed into law in April of 2015. This bill represents the culmination of more than a decade-long effort to repeal the flawed Sustainable Growth Rate Formula, or SGR, the blunt instrument that was intended to keep aggregate healthcare spending growth in check. The MACRA legislation marks a major step towards moving us away from fee-for-service to a system that rewards physicians for the quality care that they provide. It streamlines existing reporting requirements, like EHR meaningful use and the Physician Quality Reporting System, into one new program called MIPS, or the Merit-Based Incentive Payment System. Most importantly for cardiothoracic surgeons, MACRA incentivizes the development of alternative payment models and preserves the 90 and 10-day global surgical payment structure, another win for STS advocacy efforts over the past few years. Starting in 2018, physicians will choose whether to be paid through MIPS or an APM, both of which will expose physicians to both upside and downside risk. Even before Congress wrote MACRA, the Department of Health and Human Services was using its authority to accelerate the move from paying for volume to paying for value. HHS has claimed that it has already met its goal of making 30% of Medicare payments through alternative payment models by the end of 2016. Here it is important to keep in mind that at the present time, most Medicare APMs are primary care focused. However, in the future, HHS hopes to have 85% of its Medicare payments tethered to quality or value. Although we hope that APMs will eventually be the preferable path for STS members, MIPS improves on the incentive payment program ecosystem by consolidating disparate programs into one. The Physician Quality Reporting Program, Value-Based Payment Modifier, and EHR Meaningful Use programs are streamlined through MIPS. The MIPS Composite Score, which will be used to sort physicians above or below a quality threshold for bonus payments or penalties, will be calculated using metrics that cut across the 4 categories of quality, resource use, clinical practice improvement activities, and EHR meaningful use. By law, MIPS must be budget neutral, which means it will create both winners and losers, with raised financial stakes as the program progresses into the future. However, MACRA drafters clearly preferred to nudge physicians into alternative payment models, and the incentives are set accordingly. A 5% bonus will be awarded to physicians participating in APMs, and those physicians will not be subject to MIPS measurements. The stated purpose of an APM is to increase the quality of care while reducing costs and resource use, similar to the goals of the MIPS program. The catch is that not all APMs will meet the subcategory deemed by CMS as advanced APMs. In order for a physician to qualify for the 5% payment bonus and MIPS opt-out, she must participate in an APM that meets several key criteria. The APM must use quality measures similar to those in MIPS, make use of certified EHR systems, and require participants to bear more than nominal financial risk. In MACRA parlance, physicians participating in this subset of advanced APMs will be deemed qualified providers, or QPs. Any physicians who do not have access to an alternative payment model that qualifies as an advanced APM will also be subject to MIPS payment adjustments. As you can see, our new payment system is going to be very complicated. That's why our ask on Capitol Hill is that Congress continue oversight of MACRA implementation, particularly as it pertains to APM development. STS must ensure that the APM development process, to which the Society is dedicating significant resources, is not an exercise in futility. The draft regulations to implement MACRA were released by CMS on April 27th and totaled 962 pages. STS has several serious concerns with the proposal. CMS's goal to transition all physicians into APMs has been made clear, but the process by which the agency will get there and the extent to which they'll involve physicians in the development of that process is unclear. In addition, the timeline for implementation will make it nearly impossible for CMS to consider any proposals for APMs from physician groups in time for the 2017 implementation. The MACRA final rule is expected to be published in the fall, leaving just a few months for physician societies to navigate an APM submission process that hasn't even been created yet. Currently, there are no alternative payment models available to specialists that meet the criteria delineated by CMS for an advanced APM. Further, the chances of a specialty society's APM being approved and implemented as an advanced APM are slim to none. Finally, STS is concerned with the lack of specificity regarding how technical assistance funds will be spent. We believe that they should be used to help new APM designs pass muster under MACRA. So when you meet with your lawmakers on the 14th, one of the things we hope you will ask them to do is to continue to monitor the implementation of this very important law affecting physician payment. Additional letters from Congress and hearings on Capitol Hill may be required to ensure that MACRA has the effect that Congress intended. In your packets, you will have a number of materials to help you to make this case. Now I'd like to turn things over to Josh to talk about our second advocacy ask for the June fly-in.
Thanks, Courtney. Our second ask on Capitol Hill will be in support of congenital heart disease research funding. We are asking Congress to appropriate $10 million in fiscal year 2017 for the National Center on Birth Defects and Disabilities, in addition to $34.5 billion funding level for the National Institutes of Health. Every year, the STS Workforce on Health Policy Reform and Advocacy selects at least one patient advocacy issue to include in the Society's advocacy agenda. This year, that issue is funding for congenital heart disease research. The original legislation, the Congenital Heart Futures Act, was passed as part of the Affordable Care Act in 2010. Research funding under this legislation was only authorized through 2015. However, Congress continued funding the research in 2016 appropriations. Why is congenital heart disease research a priority? CHD is the most common birth defect, with nearly 1 in 100 babies affected. About a quarter of children born with CHD will need heart surgery or other interventions to survive. Thanks to recent advancements, more infants with CHDs are surviving into adulthood. That said, the NHLBI has stated that congenital heart defects are an underappreciated global health problem. Congenital heart disease research provisions in the Affordable Care Act accomplish two main objectives. They authorize the CDC to establish a national congenital heart disease surveillance system and authorize the NIH to expand and coordinate research on CHD. These initiatives have received over $10 million in appropriations since the ACA passed. STS has been pushing to extend federal support for these efforts in 2017 and beyond. The National Congenital Heart Disease Surveillance System, a key piece of the CHD provisions in the Affordable Care Act, created new infrastructure to track the prevalence and progression of congenital heart disease population-wide. Its long-term objectives are to standardize research methods, increase understanding of the public health implications of CHD, and improve patient outcomes while reducing costs. The second piece of the Congenital Heart Futures Act was to increase NIH funding meant to study CHD diagnosis, treatment, prevention, and long-term outcomes. In March of this year, STS joined a coalition letter urging Congress to appropriate $10 million in fiscal year 2017 for the National Center on Birth Defects and Disabilities, and supported an NIH funding level of $34.5 billion to bolster resources available for CHD research. Circling back to STS's request, we are asking Congress to appropriate $10 million next year for the National Center on Birth Defects and Disabilities, and we are supporting NIH funding to the tune of $34.5 billion. This slide provides an overview of some advocacy successes in the past few years. STS has gotten big wins on TAVR, lung cancer screening, and most recently SGR repeal and the preservation of global surgical payments. These efforts tend to have long time horizons, but I think everyone would agree that the results are worth the work. Up next, you'll be hearing from Madeline Sterling, who will review STS PAC functions and advocacy resources available to you.
How else can STS influence these important policy decisions? The composition of Congress matters when it comes to drafting effective public policy. It's important to ensure that the physician community at large, and cardiothoracic surgeons specifically, are both represented in and heard by Congress. STS PAC works toward that end. As the political arm of the Society of Thoracic Surgeons, the PAC, or Political Action Committee, allows cardiothoracic surgeons to participate in politics and make STS's voice heard. The PAC helps elect physicians and other allies of our specialty to Congress. The PAC exclusively supports candidates for federal office and does not get involved in presidential elections. Contributing to the PAC is one way to be an advocate, as is attending a fly-in. Hosting a site visit is another great opportunity to forge a personal connection with your member of Congress. We arrange all the details and you run the show, educating your representative with a hands-on and lasting experience. As always, please use the STS Advocacy website as a resource. You can sign up to be a key contact, stay abreast of developing policy issues, contribute to the PAC, and more. Many of you attending the fly-in are key contacts. If you're not already an STS key contact, it's easy to sign up online. Key contacts are cardiothoracic surgeons on the front lines of advocacy efforts throughout the year, committing to at least one advocacy activity per year, our go-to team of advocates for the specialty. Key contacts are the face of STS relations with Congress. We also encourage you to follow advocacy developments through our various email newsletter publications. If you have any questions regarding the upcoming fly-in or anything to do with politics and policy, please do not hesitate to contact the STS Washington office staff. We very much appreciate you taking the time to familiarize yourself with these issues. Thank you for viewing this webinar, and we look forward to seeing you in Washington, D.C.